Assalamu alaikum. Okay. Actually, thank you for Saudi Society for organizing this amazing conference, and thank you for Gilead for sponsoring this session. Today, I will talk about Biktarvy, leveraging the power of 5 for better today, tomorrow, and day to come. This is my disclosure for today's topic. So, 40 years of progress in HIV management, from multiple pills to one single tablet. Nowadays, all HIV physicians, they are thinking beyond viral suppression. All the regimen can give you viral suppression. Now we are working beyond viral suppression. We are working for effective drug, less toxicity, most powerful, a high barrier to resistance. We adapt our regimen to the patient need. So what's power 5? Long-term success, it's a major thing. We want our patient, our people living with HIV to live the best life they can. And this can be achieved with Biktarvy. So the long-term success, it's meaning durable viral suppression, combined with the powerful of treatment selection pillar, it can achieve long-term success. We'll talk about the power of 5 for Biktarvy. First of all, rapid start. In our region, we are in danger. The cases of HIV increasing day by day. The latest UNAIDS report, that's 4,000 cases per day in the MENA region. So we need the regimen that can start it from the first day. Why? Because the rapid initiation, the benefit of rapid initiation, it's shortening the duration for viral suppression. U equal U, prevent the transmission. So when you treat the patient from the day one, you decrease the risk of transmission. So we need a regimen that can be started from the day one. Increased rate of viral suppression, increased retention to care. And after that, decrease mortality and morbidity that's related to AIDS-related mortality. What about the rapid initiation? All the current international guidelines recommend the initiation of antiretroviral from the day one. Recommendation for DHHS guideline, International AIDS Society, and the EACS to give high genetic barrier to resistance medications, and the Biktarvy was one of the most common drug used. Reviewing the guidelines for treatment-naive people living with HIV, the bictegravir-based regimen in Biktarvy, it's the recommended regimen, and it can be started for rapid initiations. Why rapid initiation? Because of safety, because of decreased transmission, because of decreased the cases in our region. What about late presenter? Unfortunately, we have 20% of our populations are late presenter. It will work with late presenter? Yes. This is the Rainbow trial, the phase 4 single center study in Italy. It's accounting for 30 patients from May 2020 till January 2021. The rate of viral suppression was reaching up to 90%, and in it works, no case of discontinuation except with one patient with TB, and improvement in total cognitive function. Late presenter, they have CNS replication of the virus, they have CNS toxicity from the virus. So rapid initiation in late presenter will improve the neurocognitive functions. And this can be achieved with Biktarvy. So we can start Biktarvy with in the late presenters, and it shows significant improvement in viral suppressions and decrease the AIDS-related mortality. What about high barrier to resistance? As we say, nowadays we are looking for medication that can be given regardless of the adherence. You cannot find the perfect patient. Most of our patients, they missed 1 or 2 pills per week, per month. So we are looking for a regimen with riposte, forgiving regimen with high barrier to resistance. There is 2 important things we have to consider it in choosing antiretroviral therapy. The forgiveness, its ability of the regimen to achieve viral suppression despite intermittent non-adherence. And the barrier to resistance, it's defined by virological, pharmacological, and targeted binding property, ensuring long-term durability, reduced risk of resistance, and preservation of treatment, future treatment options. Intermittent non-adherence, it's increased risk of virological failure, increased risk of drug resistance, and transmission of the infection. And this cannot be or underrepresented in clinical trial. No one looking for barrier to resistance and forgiveness in the regimen. But it's important in clinical study, important to recommend, to consider it when you're choosing the regimen. So I know every one of you looking at this data before. The 5 years outcome of Biktarvy-based regimen in treatment-naive patient. The most important, not just to look at the data. When you give the patient regimen today, you are looking for the durable viral suppressions after 5 years. Is he will continue suppressed? Is the regimen safe and effective to be given? And it will ensure confidence with the regimen for the physician to give this regimen. And comparing the data in treatment-naive people living with HIV 5 years outcome, it's reaching up to 100 viral suppression for the 5 years. What about the subgroup analysis in those? So the Biktarvy-based regimen is working excellent in regardless of the viral load, regardless of the CD4, especially in late presenter. They have great viral suppression using Biktarvy-based regimen. What about switching from other regimen to Biktarvy-based regimen for decreasing toxicity, more simplification of the regimen, still ensuring good and sustained viral suppression for 5 years. Sorry. What about treatment emerging resistance that was observed in clinical trial? So in naive study and in switching study, there were 0 emerging resistance among all participants in Biktarvy-based regimen compared to the comparator through 5 years. What about the forgiveness by adherence? This is a really interesting real-world evidence measuring the, was published in Italy. Forgiveness by adherence, comparing 3-drug regimen, the Biktarvy-based regimen, comparing the dolutegravir 3TC. So up to 70% of adherence, it can achieving good and excellent viral suppression for Biktarvy-based regimen. Compared to the 2-drug regimen, you need as much as to 90 to 94% to have good virological suppression. What about the effectiveness in treatment experienced patients? When you are switching patient treatment experience to Biktarvy-based regimen with archived M184, this is the most common mutation was noticed in the literatures. Those patients switch to Biktarvy-based regimen still have good and high rate of viral suppressions compared to the other regimens. This is an interesting note released by WHO in January 2024. The relevance of dolutegravir-based resistance among treatment-experienced people living with HIV. Before, we are mentioning that integrase-based regimen, no need to do integrase genotype for the regimen because it's not prevalent. But latest update from WHO showed 3.9 to 19.6 increase in the prevalence of dolutegravir resistance among 4 countries. What does that reflect? That 6% of the viremic people living with HIV, they have dolutegravir resistance. The risk of the resistance, they link to 2 things. Use of dolutegravir 3TC versus the triple regimen increase the risk of dolutegravir resistance. The other, the intermediate or high integrase resistance from the beginning, increase the risk of dolutegravir-based dolutegravir resistance among patients. Next one, the experience. Do we have enough experience with the Biktarvy? I'm sure each one of you use Biktarvy in the clinic. We have now better experience with the Biktarvy-based regimen. we achieve and viral suppression and maintain viral suppression for our patients. The big star, the real-world evidence from Germany, France, and Canada, outcome at 3 years for naive and experienced, it showed viral suppressions and sustained viral suppression irrespective to treatment with zero treatment emerging resistance. What about our experience? Dr. Ala mentioned we have the biggest number. This is our data. We have 4,200 patients, most of the patients from the age 26 to 50. Our experience with the Biktarvy-based regimen. We start Biktarvy-based regimen from September 2021. We have total naive 459. Viral suppression among Biktarvy-based regimen was 99%. Switching, we switch 1,622, either from TAF FTC Elvitegravir Cobicistat or TAF FTC Darunavir Cobicistat or TAF FTC plus dolutegravir, either for simplification or drug-drug interaction with other regimen, or for better metabolic other than the BI-based regimen, and we achieve viral suppressions in 98%. What's the patient reported to us regarding? We start the patient-reported outcome among the virally suppressed patient. We collect a questionnaire to measures the adherence level for our patient. Total number of patients till now, we reach 1,200 patients filling the questionnaire. The adherence at 6 months, 96. Most of the patients, they are missing 1 or 2 tablets per month. What about the safety and tolerability? Biktarvy-based regimen give us safe and tolerable medications. Safety among all the clinical trial in naive patient and experienced patient showed well-tolerated and effective treatment among patient in Biktarvy-based regimen arms, and less drug-induced liver injury, less toxicity, adverse drug reaction in both arms. What about the switching study? So all the switching study for Biktarvy-based regimen, no reported adverse event, less GI symptoms, less rash or insomnia. The only reported the headache, and it's not related to the medication. It was in the beginning of the starting the treatment. What about our patients in East Jeddah Hospital? After switching from any TAF-based regimen with Elvitegravir or Darunavir Cobicistat or dolutegravir, we have significant reductions in GI symptoms, in the headache. We have better sleep quality in our patient after switching. And we are still collecting the data regarding patient-reported outcome after switching. Last thing, the person-centered approach. Nowadays, HIV management should be person-centered. We cannot focus only on viral suppression. We have to choose the perfect regimen for the patient. All the regimen they can give you and maintain sustained virological suppression, but we have to focus on long-term high quality of life. So we have to give the regimen for regardless of the age, regardless of the sex, with the better pregnancy, or if she is wishing to have pregnancy, any toxicity from the medication, we have to eliminate it. The patient preference, simplification of the regimen, the socioeconomic, any mental and physical health. So the selection of the medication should be person-central, and it should be consideration of those all factors. So the BRO. Nowadays, all HIV physicians, they are looking, and we have to monitor the patient-reported outcome. Why? Because our patients, they are not complaining. We have to look for the better regimen. We have to decrease the unnecessary side effects, and we have to work on the psychosocial pattern of the medical care for our patients. So PRO in ART naive patients and in switching therapy showed less GI toxicity and less GI side effect related to the Biktarvy-based regimen, less loss of appetite, difficulty of sleeping is better with Biktarvy-based regimen, less depressions and dizziness and all the same side effect. It's less in the Biktarvy-based regimen compared to dolutegravir, abacavir, 3TC. What about the quality of sleep? It's less in Biktarvy-based regimen in the study of 1489 and 1844, comparing the dolutegravir, abacavir, 3TC with the Biktarvy. And let's say the most simplest thing for this. They have favorable pharmacological characteristic, simple administration profile. It can be given as single tablet regimen. Those with or without the food, it's regardless of the food, fewer drug interaction. We don't have the booster of cobicistat, so they have fewer drug interaction, and it can be used with the mild to moderate hepatic impairment and mild to moderate of renal impairment. Unless the GFR less than 30, we have to avoid it. So this is from one of my patients. This is his experience. I asked him to write the experience about his regimen. It's single tablet regimen. According to him, no side effect, no abdominal or GI side effect. He was happy about the size of the pills, about the, he can take it at any time, regardless of the food, and he achieved viral suppression within 4 weeks from starting the treatment. So power of 5 mean you can start it as rapid start, high barrier to resistance, person-centered, safe and tolerability of the regimens, and experience with the Biktarvy now for 5 years, all the data from clinical trial of naive or switching, and the real-world evidence showing the safety and efficacy of the regimen. I will end up with the key studies from CROI. It was in 2023, influencing the clinical practice and changing the guideline. The IMPACT 2026, it's a phase 4 prospective trial measuring the Biktarvy in pregnancy and postpartum, its PK and virological outcome. They enrolled 27 women and they measured the Biktarvy level in the second, third trimester and postpartum. The Biktarvy exposures in pregnant women was lower, but remain above the effective concentrations for pregnancy, and no infant transmission of HIV among those ladies, and 90% of participants achieve virological suppressions at delivery. So after this large, the only BK trial in the Biktarvy-based regimen, the DHHS guidelines recommend Biktarvy-based regimen as alternative for women who are planning to be pregnant or pregnant whilst on Biktarvy-based regimen. So in conclusion, Biktarvy associated with robust and durable virological efficacy in broad range of setting. It's well tolerating, it's a forgiving regimen, no emergent resistance, it's have positive patient experience, and is suitable for rapid start. So Biktarvy provide confidence and peace of mind for better today, tomorrow, and days to come. And this is the end. Thank you.